today's class we'll discuss about antibiotics, how it evolved along with the medicine, what are the prospects that we should understand, and what are the future prospects that we should be very wary of. So, as far as concerned, today's discussion is on principles of antimicrobial therapy and antimicrobial stewardship that you have to understand. Now, as far as the human history is concerned, as William Osler has said, that human race has been plagued with three main factors. Those are the war, the famine, and fever. Obviously, fever has raised over the years, and there are many causes of the fever, and one of the very important causes are the infective diseases. Now, if we look at the historical times, that is the pre-antibiotic era, we can see people had used many forms of therapy. The many of the notable forms was first, as you can see in this picture, it is called as bloodletting. Alternatively, many other chemicals like mercury was inhaled to the patient in the form of fumigation. Some of the other pretty much bizarre methods would include letting the patient wound get dressed with and eaten with leeches, or use of honey or silver particles. However, some are not so bizarre. As of today, we do understand for anti-malarial therapy, the drugs that are used, all the chemicals have evolved from, for example, the quinine has evolved from cinchona tree. Furthermore, prior to the antibiotic era, the treatment of diseases with antisera was seen when Pierre-Paul-Émile Roux demonstrated the efficacy of antidiphtheritic serum. Then comes the breakthrough in the 1920s when Alexander Fleming observed the inhibition of Staphylococcus on a culture plate on which a fungus has already grown. This fungus was known as Penicillium, and he called this substance as penicillin. However, 20 years down the line, this molecule was then extracted from the fungus to be used for the human use. Now, if we look at the timeline of the antimicrobial agents that we have obtained, round about the First World War, when penicillin was used for treatment of infective conditions, thereafter there was a huge surge with discovery of newer antimicrobial agents from natural sources or synthetic or semi-synthetic sources. However, if we look at the last 3 to 4 decades, there have been rare scarcity of newer antimicrobial agents. Furthermore, during this period, we encountered what is called as antimicrobial resistance. That is, we have started to get more and more number of cases where the microorganisms are being resistant to the most of the antimicrobial agents known. And hence, in the year 2010, the United Nations declared the antimicrobial resistance as a fundamental threat to the human population. Now, if you look at the sources of the antibiotics, you can see most of the sources comes from other organisms like actinomycetes or other bacteria, fungal, and some of the antibiotics are synthetic. That is, they are synthesized artificially. Moving on, if we look at the classification of antimicrobial agents, we can classify them based on the type of the organisms they are effective against. For example, we can classify them into either antibacterial agents. A very special group of antibacterial agents would comprise the antimicrobacterial agents. Furthermore, the other pathogenic drugs could be antifungal, antiparasitic, and antiviral. As far as today's discussion is concerned, we'll discuss about the antibacterial drugs. Now, all the antibacterial drugs, they have some kind of effect on bacteria but not on human cells. That is the ultimate purpose. If we look at how they are effective. The most common place where the antibiotics act are the cell walls of the bacteria. This is also called as cell wall acting bacteria. The other methodologies could include interference in the nucleic acid synthesis, either DNA or RNA, or interference in the folate synthesis like sulfonamides, or they could interfere with the protein synthesis or interfere by directly acting on the cell membranes. Based on the mechanism of the action, we can classify bacterials into many types. So the first, the antibacterial agents which act on the cell wall. The most important group would include the penicillin. Now, penicillin, as I have already told you, it was the first antibiotic agent that was discovered. Later on, the penicillin was further modified based on the requirement. For example, if you look at the classification, we have the natural penicillins. However, these natural penicillins are not acid resistant. Hence, they are neutralized by the gastric acid. The modification was done by adding the amino group, thereby making it resistant to the gastric acid. These penicillins are called ampicillin or amoxicillin. Furthermore, when it was discovered that penicillin was a type of an enzyme produced by the bacteria which degraded the molecule, it was further modified to make what is called as penicillinase resistant penicillins. Those would include oxacillin, flucoxacillin, methicillin, and naphthalene. Another modification of penicillin was done by adding either a carboxyl or a sulfur group or the uridopenicillin. These group of penicillins, which comprise of the ticarcillin or piperacillin, they have a very thin molecule, hence they are very effective against the gram-negative organisms, especially with the activity against Pseudomonas. However, with the discovery of penicillin, one more important discovery did happen, that is called, also I think you have heard about, it is called as the methicillin resistant Staphylococcus aureus. When the Staphylococcus aureus infections were treated with penicillins, it was discovered initially they were resistant to penicillin, then to the aminopenicillins, and it was further modified with the penicillin resistant penicillins. Later on, it was found that this particular strain of Staphylococcus aureus was resistant to even penicillin resistant penicillins, more importantly, resistant to methicillin. Then it was found out the resistance was due to modification of the beta-lactam ring. Hence, this particular strain, also called as methicillin-resistant Staphylococcus aureus, renders all beta-lactam antibiotics as ineffective. Now, if we look at the next group of classification, this is how penicillin can also be classified based on the source, the spectrum of activity, the resistance to enzymes, and resistance to acids. The next important beta-lactam group of antibiotics would include the Cephalosporins. We have till now about 6 generations of Cephalosporins, and if you look at the spectrum of activity of the Cephalosporin, you can observe that the range covers from gram positive to gram negative as the generations increase. That is, the first generation Cephalosporins have a more gram positive coverage, whereas the later generations have more gram negative coverage. An important antibiotics that you should remember as far as the cephalosporins is concerned is the 5th generation cephalosporin or the anti-MRSA cephalosporin. These cephalosporins, although being a beta-lactam, are effective against MRSA. Other than that, we have a specific group of beta-lactam drugs called as the Carbapenems. The Carbapenems, as we till now, we have 3 groups, and broadly speaking, if you see this group, we have the group of imipenem, meropenem, which have an activity against the gram-negative, especially Pseudomonas aeruginosa and Acinetobacter baumannii. Both are associated with multiple drug resistance. The newer group, comprising of the tomopenem and the razupenem, they not only have the anti-pseudomonal or anti-acinetobacter activity, but they even have activity against MRSA. Moving on, the next group of antibiotics which act on cell wall would include the glycopeptides. More importantly, we have vancomycin, teicoplanin, and ramipril. Now, vancomycin, if you remember, that was the drug that was advocated for use of infections caused by MRSA. However, as with most of the cases, today we are seeing even vancomycin resistance, either in intermediate susceptibility or totally resistance. Nevertheless, moving on, after the cell wall antibiotics, we have the antibiotics acting which interfere with the protein synthesis of the organism. These would include aminoglycosides. Among the aminoglycosides, we have the gentamicins, kanamycins, neomycins, streptomycins. Then we have tetracyclines, macrolides, which would include drugs like azithromycin, erythromycin, and ketolides. And moving on, we have lincomycins, chloramphenicals, and oxazolidine group of antibiotics. Furthermore, there are some specific group of antibiotics which interfere with the nucleic acid, that is the DNA or RNA. Most important among this group would be the fluoroquinolones, and we have 4 generations of fluoroquinolone, the first, second, third, and fourth generations, and along with that, lipomycins. Now, coming to the antimetabolites, this group of antimicrobial agents interfere with specific metabolic pathway of the organism. Hence, they are called antimetabolites, and most importantly is the sulfomethoxazole, which interferes with the folate synthesis. The last but not the least part is drugs which directly act on the cell membrane, not on the cell wall but cell membrane. The important drugs would include the lipopeptides and the cyclic polypeptides, which include polymyxin B. Most of the time you will find in the hospital setting, polystins and the polymyxin B are the last resort for the gram-negative multi-drug resistant organisms. Like you have understood that the antibiotics act on various processes of the normal functioning of the cell wall, the bacteria also develops many pathways or ways to circumvent the action of the antibiotics. Those would include, most importantly, efflux pumps. What are efflux pumps? Please remember that the bacterial cell wall has some pumps. These pumps enable the bacteria to allow some nutrients or minerals or the salts to enter into the cell for the normal functioning, and similarly some pumps which allow for the expulsion of the many particles. Some of these efflux pumps have mutated or they have evolved so that they can throw out the antibiotics that have entered into the cell. This is commonly seen with fluoroquinolones, rifampicins, and some of the beta-lactams. Some of the antibiotics, they interfere with the metabolic pathway, so the bacteria then evolves bypassing this metabolic pathway, as that can be seen with sulfonamides. Many bacteria circumvent the antibacterial action by modification of the target molecule. For example, vancomycin attaches with the cell wall. It has got a target molecule. The organisms which become resistant to vancomycin alters this molecule on the cell wall, thereby rendering the antibiotic ineffective. And the final but most important part is the enzymes that are produced by the bacteria. These enzymes directly act on the antibacterial agents and make them ineffective. Most important would be the beta-lactam group of antibiotics, and these enzymes are also called as beta-lactamases. The beta-lactamase enzyme, there are many enzymes which have been identified till today. There is a specific classification based on the molecular classification, that is the functional classification, or the enzymatic classification, based on whether they have the serine proteases or the metallo-beta-lactamase, and the functional classification will involve the kind of the antibiotics they actually degrade. Now, this was all about the antibiotics that we use. The next comes the very important part is how to use the antibiotics. This would include the antibiotic therapy. Now, if you look at the antibiotic therapy, the first important part of the treatment is called as empirical treatment. Now, what do we mean by empirical treatment? Empirical treatment basically means when you approach the patient, you don't have a definitive diagnosis. Yet, the clinical examination and your provisional diagnosis is indicative of an infective pathology. Then you must have to give antibiotics. But then comes the question, what group of antibiotics, what would be the ideal dosing? That is given is called as empirical treatment. So, the empirical treatment is the treatment that is given based on experience without the precise knowledge of the organism or their susceptibility pattern. Most of the time, this empirical therapy is designed based on the hospital anti-guideline or the national guidelines, and these are most commonly initiated within the 24th hour of admission. The next part of the treatment would is called as the preemptive treatment. Now, after you have started the patient on empirical therapy, you start to get some investigations done. Now, this investigation would give more of an indication of what kind of pathology the patient is having or the organism that could be causing this disease. Based on these indications, we can further narrow down the antimicrobial therapy. This is called as preemptive therapy, where we narrow down based on the clinical imaging or any kind of serological or antigen antibody assays. The final part of the treatment would be definitive treatment, where now we know what is the exact disease that is occurring in the patient, the exact microorganism or the bacteria which is causing the disease, and their susceptibility pattern. Based on that, we can choose the specific antibiotic and the dose in that patient. This is called as definitive therapy. I think you have understood this part. So, for empirical treatment, we generally go for a broad spectrum antibiotic so that we can cover a lot of organisms. When we have the preemptive treatment, we narrow it down based on the possible causes. And finally, in the definitive treatment, we give the antibiotic that is required definitively and which we have been shown to have in vitro efficacy in the laboratory testing. Having understood that, now we have to understand what is the goal of the antimicrobial susceptibility testing. That means after you get the culture report, the antimicrobial susceptibility testing has been done. But then what is the goal? The primary goal is to provide an accurate in vitro susceptibility testing results which can be interpreted and carried out on the patients. Furthermore, it will also give what is called as antibiogram. I'll talk about antibiogram later on. But the most important goal is it test and monitor the effectiveness of therapy. For example, before having the culture susceptibility report, we can give empirical therapy or preemptive therapy. But we cannot say that this therapy would be effective in that particular patient. However, if we do get the culture and susceptibility report, we can say in the likely scenario of this condition, we can say that this particular antibiotic will be effective. This is called as the effectiveness of therapy. So, the antimicrobial susceptibility testing predicts two important parts. One is it predicts the effectiveness and it monitors the effectiveness. Now, how can we predict the effectiveness? We have some testing pattern. In India, we use either CLSI or the European guidelines. Basically, most of the countries have their own set of guidelines. In India, till now, we don't have a specific guidelines. That is the reason why we follow the international guidelines, CLSI or the UCAST. Now, based on these guidelines, we have some methods which predict the effectiveness of therapy. That means whatever antibiotic we do give, how can we predict? The most commonly, I think you have all seen this plate. This is called as disk diffusion method, or also called as the Carbapenems method, in which the organism is plated on a plate and antimicrobial disk containing antibiotics in specific amounts are placed on it, and then we can see a particular zone of inhibition. Now, this zone of inhibition, if we do measure and we correlate with the zone sizes already given in the standard guidelines, that is the CLSI guidelines, we can predict whether this would be sensitive, intermediate, or resistant. That means whether in vivo the antibiotic will be effective or not. Another method is also called as the MIC method or minimum inhibitory concentration method. What is this method? If we look at this method, we are only measuring the zone size and we are giving the report based on the specific guidelines. But actually, we are not testing the exact antimicrobial concentration. Over here, we are calculating the exact antimicrobial concentration, also called as the minimum inhibitory concentration. That is the minimum concentration of the drug which inhibits the growth of the microorganism. Now, why we generally do prefer the disc diffusion? Because it is less laborious. This method is more laborious and more tedious. A common ground is also called as the E-test or gradient diffusion, where instead of a disc, we have a strip which have gradient of antimicrobial concentration. And you can see there is a epsilon shaped zone of inhibition. If you look over here, this is the edge of the zone of inhibition, and the concentration over here would indicate the minimum inhibitory concentration. Alternatively, we can go for automatic methods like Vitek or Phoenix methods, in which the growth curve analysis detects the MIC concentration. Furthermore, as you have learned, probably the most important cause of antibiotic resistance is by production of enzymes. Now, enzymes are proteins, so they will have its own genes. We can directly detect the genes in the microorganism by molecular methods. If the genes are present, it is highly likely that the organism will produce the enzyme and hence become resistant. Now, the next part is called as MBC or minimum bactericidal concentration. Now, what is different over here? Earlier we said that MIC is the minimum inhibitory concentration, that is the minimum concentration which would inhibit the propagation of the bacteria, whereas MBC is the minimum concentration which would kill all the bacteria. So, please look over here, we have serial dilutions of the antibiotics in which we have a specific number of bacteria. Now, as we go on increasing the concentration of the drug, the number of bacteria will increase. Now, this is the concentration which is also called the MIC, where the turbidity would not increase. That means the bacteria is not reproducing. That is the inhibitory concentration. However, if we take this solution and culture on a plate, we can observe both of organisms. That means the organisms are still viable. If we go on increasing the concentration at this point, if we do a subculture, we will find no bacteria now has grown up. That means all the bacteria in the solution are dead. This is called as the minimum bactericidal concentration. Now, having said that, you must understand why this is important. When a human being gets infected with an organism, the body also fights against the organism. There are various methods. Predominantly, you would say the neutrophils will be acting very fast. Now, that's a constant battle that the body has to encounter with the increasing number of organisms. That is, the organisms are reproducing at a very fast pace. When we give the antibiotics, our goal is to prevent the reproduction of the bacteria. That is the MIC concentration. If we are able to do that, we can tell this disease process and the human body will itself recover from the infection. However, we do get some specific class of population, like the people who are immune compromised, people who are critically ill. They have lost their own mechanisms to fight against any infections. In those patients, we only give the dose in the concentration of the MIC. The infection will not be cured. The organisms will still be there. When the antibiotic doses are stopped, it will flare up. Hence, it is very important to know what is the MIC and the MBC of a particular drug. As far as tests to monitor the effectiveness, we can go and detect the serum concentration of the antibiotics in the patient itself, thereby helping us to know whether the dosing has been adequate or not. However, it's a very tedious and laborious process, and similar to that, I think you have already learned about therapeutic drug monitoring. Similarly, there are many antibiotics which have a very low ceiling of the dose. For them, like vancomycin, we have to do what is called as therapeutic drug monitoring, so that we do not give the drug at a higher concentration than the body can take up. Many other tests which can effective, among them a very important would be an antibiotic synergy test. Synergy test also detects multiple drug resistance against multiple groups of antibiotics. Having the test being done, it is reported. Now for that reporting, the CLSI have already given a particular group of antibiotics like the A, B, C, U and others. What is this group? The A group is for the primary test reporting, the B group for the selective reporting, the C for supplemental testing. That means whenever you do prescribe for a culture and susceptibility report, the reporting will be done based on this classification. That means please do not expect that for a sensitive strain all the susceptibility testing against all group of drugs will be done. Based on the patient's illness, whether the patient is critically ill or not, whether the outpatient, this will be modified by the laboratory itself, and that you should be aware of. As far as the report is concerned, if you do observe a culture susceptibility report, you will find against various antibiotics, we have some of the specific words that are written. Those would include whether susceptible, whether intermediate, whether resistance or non-susceptible. Well, you must understand what these words mean. Let us take up them one by one. First is susceptible. What do you understand by susceptible or sensitive? That means based on the normal dosing of an antibiotic agent, this antibiotic will be effective in most cases. That means the standard dosing would be effective. That is called as sensitive. And then what would be resistant? The exact opposite. That is, based on the standard dosing, the antibiotic would not be effective. As simple as that. Now, what is intermediate? Intermediate susceptibility means that the organism has been seen to be susceptible in the laboratory conditions. However, we should be aware of the kind of infection that is occurring. Why? Because some of the antibiotics, I think you have learned in pharmacology, based on the PKPD parameters, they are excreted either through renally or through the hepatic system. So some of the antibiotics will concentrate in the urinary tract but not in the blood. So if this antibiotic is given for an UTI, it might be effective but not for a patient in sepsis. So all the drugs which have been reported as intermediate has to be based on the type of the antibiotics and the type of the infections. Two more important terminologies that you should understand. First is called as a susceptibility dose dependent. What does it mean? That means the organism is inhibited by achievable concentration. However, when a different dose regime, that is a higher dose or frequent dose, the recommended dose drug will be likely effective. What it means is, for us antibiotic which is susceptible, that means normal dosing would be effective. But if the report comes as SDT, that means we have to give a higher dose. Either we have to increase the number of dosing or you have to increase the dose itself. The last but not the least is a report called as non-susceptible. What it means is, there are some bacteria for which we do not have a epidemiological cutoff criteria upon which we can say a particular strain is resistant or not. The only thing we can say is based on the normal standard dosing whether it would be effective or not, that is susceptible or not. For those bacteria we call it as non-susceptible. I hope you have understood about this terminology. Now coming to the most important part of the MIC, while choosing the antibiotic, we have to look at three very important factors. The first important factor would be the clinical scenario. What is the patient profile? What is the parameters of the patient? We have to understand that is the renal clearance, that is the volume of distribution. You have to take all these factors. Furthermore, you have to ascertain the site of the infection, what is the vascularity of the site, the volume of distribution. All these parameters have to be taken in consideration. Furthermore, you have to consider the action of the antibiotic, whether the antibiotic is excreted renally or is metabolized hepatically. What would be the volume of distribution of the particular antibiotic? What is the half-life of the antibiotic? And finally, you have to consider the microbial aspect. That is, what is the type of the microbe you are fighting against? What are the common resistance pattern that can be seen? What is the in vitro susceptibility pattern? So these three factors are the most important factors which will help you to choose the antibiotics. I think most of you will be aware of this figure. So this is a figure which shows the serum concentration of any antibiotics after it has been given. Now look at this picture. This is the initial part where the drug is injected into the patient, after which the drug will reach a peak concentration in the blood. This is called as the Cmax. Thereafter, the blood will distribute and elimination of the drug will start. So the concentration of drug will, this is the MIC cutoff, that is the minimum inhibitory concentration. This is the area, that is the concentration which is above the MIC. This is also called as area under the curve above MIC. And if we look at the duration from this point to this point, where the concentration of the drug is above the MIC, it is called as a time above MIC. Now why this is important? Because antibiotics can again be classified based on how effective it is. That is, whether it's a concentration dependent, or whether it's a time dependent, or it has a post antibiotic effect or not. For example, some of the drugs like Aminoglycosides and Fluoroquinolones are concentration dependent. That means the higher the concentration of the drug in the blood, the more effective it is. However, if we look at the beta-lactam group of drugs, they have the time dependent. That is, the higher the concentration of the drug for a prolonged period of time above the MIC, the more effective it is. So based on that, some antibiotics will have the most important characteristics as the peak by MIC, that is highest concentration that can reach above MIC, or time above MIC, that is the duration above which the concentration remains above MIC, or the area under the curve, that is the 24-hour area under the curve above MIC. These are the specific factors which are important in choosing the antibiotics. Well, I am not going into the details. These are based on the pharmacokinetic and the pharmacodynamic parameters, based on which I think you already know the zero order kinetics, the first order kinetics, based on which it can be type 1 or concentration dependent, or type 2 or time dependent, or type 3 which is time dependent but having post antibiotic effect. Now why these are important? Because emergence of resistance. Now look at this picture. When we are giving the antibiotics, if the concentration is below the MIC for a prolonged period of time, it will push, that is, there will be a selective pressure for preference of some organisms or some population of the same organism which will become resistant. Eventually, after the therapy, we can see the resistance occurring. For example, look at this picture. Initially, if the load is very low and you have given the same dose, most of the bacteria will be killed. However, if the load is higher, what will happen? Almost all will get killed, but some will still remain. These are the resistant groups. And when the antibiotic is withdrawn, this mutant population will then again propagate, and which will definitely lead to recurrence of the same infection by the same organism but now resistant, and furthermore it will lead to failure of the antibiotic therapy. Just look at this. This is the most important part. What is the concentration above the MIC? Okay. So this gives us what is called as mutant selection window. That means if we keep the concentration of the drug above MIC, we can prevent the mutation also. Slightly higher, that is called as the mutation prevention concentration. Many antibiotics like beta-lactam have a mutation prevention of 4 times the MIC. Similarly, Aminoglycosides and Fluoroquinolones have their own level of mutation prevention concentration. So all this would be based on the PKPD consideration, which will become extremely important if you are dealing with patients who are critically ill. Because in critically ill patients, not only the chances of infection are higher, these people are more commonly likely to get infected with resistant organisms which are prevalent in the hospital setting. Furthermore, their PKPD parameters will be deranged because of their critical illness. The next part of importance is of antibiotic resistance. Rampant use or misuse of antibiotics have led to today's present state of gross antibiotic resistance seen in all settings, whether it's a primary care setting or a tertiary care setting, in the community level or in the hospital level. WHO has taken some action to prevent this antimicrobial resistance. The first action that they have taken is to classify the antibiotics in a way. This is called as the AWARE classification. What does AWARE stand for? A stands for access, WA stands for watch, and RE stands for reserve. That means there are some particular group of antibiotics which we have common access, which we can use easily. Some of the antibiotics we have to be the use of these antibiotics has to be very watchful. That means we should use them when there is a proper need. And some drugs has to be left untouched. They has to be used only in case of severe conditions. Those are called as the reserve drugs. Now, among these drugs, if you see this picture, the access group have the most number of oral drugs. But the number of oral drugs reduces as we go from access to watch to reserve drug. So, it is very eminent that whenever you are using antibiotics in the outpatient or in non-serious patients, try to prefer the oral antibiotics which belong to the access group. If you go and look up the WHO website, there is a list of classification in which each and every antibiotic has been classified based on that. A stands for access, W for the watch, R for the reserve group, and there is another classification for others which are under experimental or not for routine use. That is what WHO is doing at the global level. Yet, each and every hospital or institute has to take the actions on their own hand. This is determined by the Antimicrobial Stewardship Program. Now, what it means is, as the name already suggests, antimicrobial means we are dealing with the antibiotics. Stewardship means like a captain of the ship stewards the ship based on the direction and the speed. We need to steward the use of antibiotics in the hospital setting also. This whole program is called Antimicrobial Stewardship Program. Now, what does this program encompasses? As CDC have said, antimicrobial stewardship is use of the right antibiotic for the right patient at the right time, at the right dose, at the right route to cause least harm to the patients of now and of future. This is in short antimicrobial stewardship. And why it is needed? Obviously because of the increasing antimicrobial resistance, use and misuse of antimicrobial agents, and we have a poor antimicrobial research. As I have already said, for the last 3 to 4 decades, we have very scarce number of newer antibiotics that are coming up for human use. Now, to implement the MSP, obviously the hospital has to take the leadership action to formulate a team. The team is also called as Antimicrobial Stewardship Team with proper infrastructure support and framing of antimicrobial policy. Now, coming to formulating Antimicrobial Stewardship Team, all aspects of the hospital should be included in this team with a multidisciplinary committee and an antimicrobial steward who would direct and implement these policies. Furthermore, the hospital should have a proper laboratory setup to identify infections at the earliest, along with other biomedical, other tests, non-microbiological tests which would indicate the infections, and a robust laboratory and hospital information system so that the communication barrier would be avoided. Furthermore, the antimicrobial stewardship team should formulate an antibiotic policy which has to be followed in the hospital. Now, this antibiotic policy should be based on the hospital antibiogram and based on the national antibiotic policy. In India, we do have an antibiotic policy. If you look up the web, we have an antibiotic policy made by the ICMR and the AIMS team. They have already made the antibiotic policy. You can go and look up. It will be very much helpful for you to learn how to give antibiotics in various cases. Now, the stewardship, I will be very brief in how this stewardship occurs. It occurs in two ways. One is called as the front end, other is called the back end. Now, what in the front end, what is done is, right in the pharmacy, we restrict the use of the drug. Like the WHO classification, we will restrict some group of drugs which cannot be used until and unless a specific team or the infection control team has been consulted upon, thereby restricting the use. However, this method has its own problem. Some patient might be in dire need of some drugs which can be restrictive in nature. Furthermore, it causes hindrances and does not help in the teamwork. A more profound or a better method would be to use the back end strategy. That is, whenever you are using any antibiotic for a patient, the team will consult you regarding the same questions like the antimicrobial stewardship I already said. That is, whether the right antibiotic was chosen for this patient, what was the route and the dosage administration was done properly or not. This method not only helps in educating all people, including the doctors and the nurses and the pharmacists, and thereby making people more and more aware about this program. And this is more acceptable of the two methods. Then we can also assess whether this policy is working. There are very indicator methods like the use of the antibiotics, what is the outcome. These indicators can help. Furthermore, the doctors of the future, what you need to understand is these 2 points. First is prescribe only when it is indicated. There is nothing like prescribing an antibiotic when you don't understand. You have to prescribe the antibiotics only when there is a definitive indication. If there is no indication of antibiotic, withdraw it as soon as possible. Next, how to validate? We have to inculcate what is called as culture of cultures. Many a times you will find many clinicians very confident about their provisional diagnosis and start prescribing the antibiotics, not even bothering to go for the microbiological diagnosis. This will ultimately be very, very harmful. May not be for a single person, but this habit and this method followed by a large number of doctors on a large scale will be very, very harmful. So what you need to inculcate is go for the definitive therapy as far as possible, as much as possible. And the definitive therapy can be given only if you have a culture and susceptibility report. So what you need to do is you have to inculcate a culture of cultures. Next, I have already said empirical therapy and targeted therapy. That means we always have to start with the empirical therapy and then end up with the targeted therapy. With that, we can either have to de-escalate, that is, go down the spectrum of antibiotics, or escalate. For example, this is a spectrum of antibiotic for a particular organism. We can move above or move down. That means more effective but antibiotics which are prone to resistance. If we move above the ladder, it's called escalation. If we go down, it is called as de-escalation. Next, we have to select the antibiotic based on the site of the infections. For example, in case of pneumonia, the site of infection is lungs. Some of the drugs will be more effective in the pulmonary circulation, may not be effective in other sites. So based on the site of the infection, you have to choose the antibiotics. Some antibiotics will be very effective in the urinary tract, may not be effective in the bloodstream. The next important part is avoid administration error. That is, you have to be very careful when you are starting the antibiotic. The first dose is also called as the loading dose. Your loading dose should be appropriate. Then some of the drugs may have to be infused, that is, given over a long period of time. Some of the drugs have to be given in a short period of time, or some of the drugs there has to be a renal adjustment. You might have a patient with a renal failure. So drug dosage administration has to be also be very important. Next, coming back to the microbial parameter, the therapy should be MIC guided based on the susceptibility pattern. And for some drugs like Vancomycin, therapeutic drug monitoring should be done to avoid the adverse effect. The final part that I'll touch upon is called as the hospital antibiotic. More and more, as you start to work in the hospital setting, you will be becoming aware of hospital antibiogram. Now, what is hospital antibiogram? Suppose after a few days, you start working in the medicine world. Now you have a patient of, say, urinary tract infection. So you need to prescribe an antibiotic. From the community studies, you know that most commonly the organism causing UTI is Escherichia coli. You know that. You know there are many antibiotics will be effective, but you don't know what is the antibiotic spectrum that is going on in the hospital. If you do know that, then you can prescribe in this setting. That knowledge is given by what is called as hospital antibiogram. This is an example of hospital antibiogram. Look over here. For example, the E. coli that is obtained for the urinary tract infection, it is tested upon by at least 20 isolates. The result of the 20 isolates, as we can see over here, we can see almost 100% susceptibility for cholesterol. But that is a reserve drug that we cannot use. What we can use, if we see, some drugs have, like meropenem, have 82% effectivity. Some have 85%, like amikacin. While some, like ciprofloxacin, have very poor efficacy. For example, 25. So if we are given a choice to choose an antibiotic from this hospital antibiogram, more often not we will choose for a amikacin, because it has got a higher efficacy and we can easily access this drug. So this is the way a hospital antibiogram will help you to choose what antibiotic to use in which setting. So that was all about the today's class. I think I have made a very brief discussion about what antibiotics are, how to use them, and the importance of antimicrobial resistance. And in this setting, that is the setting of antimicrobial resistance, the importance of antimicrobial stewardship.